Hi, I'm Matthew Tremblay, and I'd like to provide you with some information about the impact of multiple sclerosis treatments on COVID-19 outcomes and vaccination. As everyone is familiar, COVID-19 is a viral pneumonia caused by the novel coronavirus SARS-CoV-2, which was originally identified in Wuhan, China in late 2019. The illness was later declared a pandemic in early 2020, and as of August 2021, there were over 37 million cases of COVID-19 in the United States, with over 600,000 deaths, and worldwide over 200 million cases of COVID-19 with over 4 million deaths. Early in the course of the COVID-19 pandemic, the National MS Society, the Consortium for MS Centers, and other organizations within North America developed a registry to understand how patients with MS dealt with COVID-19. The registry is referred to as COVIMS, and the results of the registry were recently published in a work authored by Salter et al. In JAMA Neurology 2021, publishing the results of 1,626 cases recorded between April 2020 and December 2020. The key findings of the COVIMS registry were that there were a number of risk factors for severe COVID, which included older age, ambulatory disability, Black race, recent use of corticosteroids, cardiovascular disease. Additionally, the researchers found that some medications increase the risk of hospitalization, including rituximab and ocrelizumab. The next question that we want to explore was the effect of MS medications on COVID-19 vaccine. Most MS medications are immunomodulators that weaken the effect of the immune system, and there was concern that the medications may limit the potential for vaccination against COVID-19. The first two vaccines developed to treat COVID-19, or rather prevent COVID-19, were mRNA vaccines, with the Pfizer-BioNTech vaccine being the first authorized by the FDA, and Moderna having the second mRNA vaccine approved for prevention of COVID-19. Some of the earliest data regarding the effect of COVID-19 vaccine and MS were regarding side effects, and the paper from out of Israel by Acheron et al. Suggested that the side effects in people with MS treated with mRNA vaccines were similar to the general public and with no significant risk of relapse. The next publication regarding MS medications and COVID-19 vaccination gave us the first sense that some of the medications we suspected might blunt or impair vaccine responses did in fact do just that. In the paper from Acheron et al. Regarding antibody responses in patients on MS medications, they found a significant reduction in antibody responses in patients on both ocrelizumab and fingolimod, a medication that goes by the brand name Gilenya. Out of the 44 patients treated with ocrelizumab, they found that only 10 had positive antibody testing, which is 22.7%. And in patients taking fingolimod, they found that only 1 out of the 26 patients had positive antibody testing, representing only 3.8% of the patients tested. The next publication regarding the effect of MS medications on COVID-19 vaccines comes from a group of researchers out of Italy who conducted a multi-center study evaluating the effect of many of the medications used in MS on antibody responses to the COVID-19 vaccines. The study evaluated responses to both the Pfizer and Moderna vaccines that are available in the United States. For most medications used to treat MS, the antibody levels were similar to patients who were not on any treatment with disease-modifying therapy. However, patients on rituximab, ocrelizumab, and fingolimod had reduced antibody responses, as was reported in the Israeli study. As a piece of reassuring information, there were 2 research studies looking at the effect of ocrelizumab and rituximab on vaccine responses. And while those 2 studies did confirm, as seen in the Acheron et al. And Sormani et al. Papers, that patients on those medications had reduced antibody responses, they did find that patients who failed to develop antibody responses to the vaccine typically had higher numbers of T cells against the virus after being vaccinated. In parallel with collecting information about our own patients at the RWJ Barnabas Comprehensive MS Center who were infected with COVID, we were able to evaluate the prevalence of antibodies against the SARS-CoV-2 virus in patients who had recovered from COVID-19. And what we found was that patients who were treated with ocrelizumab and rituximab were less likely than people on other MS medications to develop antibodies after recovering from COVID-19. Similar to the findings of this study by Acheron and Sormani and others, we also found that patients treated with ocrelizumab and rituximab had a much lower probability of developing antibodies in response to vaccine, with patients on ocrelizumab developing antibodies about 44% of the time, and patients on rituximab developing antibodies only 16.7% of the time, while patients on other MS medications had over 95% likelihood of developing antibodies after vaccination. Early in 2021, tests became available to evaluate for antibodies against the SARS-CoV-2 virus, and a number of tests became available that allowed us to quantify the amount of antibodies patients had against the virus. This enabled us to evaluate how much antibody patients were making after being vaccinated. What we found was that patients on ocrelizumab very rarely had what we refer to as high titer, or very large amounts of antibody after vaccination. Similar was seen with patients on rituximab, which has the same mechanism of action. The S1P modulators like Gilenya, while often resulting in positive antibody testing, usually were found to have low titers, meaning very small amounts of antibody after being vaccinated, when compared to people who are not on immunosuppressants and people on most other MS treatments. We believed that vaccinating patients taking rituximab and ocrelizumab could potentially be maximized by selecting the right washout period, meaning waiting a certain amount of time after the last infusion before receiving the vaccine. However, what you'll find on this graph was that even at a full 6 months of washout period, only about 62% of patients on ocrelizumab and rituximab were able to develop an antibody response to their vaccine. We next decided to look at the importance of the B lymphocyte numbers in the circulating blood as a potential predictor of whether somebody would develop antibodies in response to the vaccine. What we found was that patients who had more than 20 CD19 positive B lymphocytes in circulation on their blood tests were essentially guaranteed to develop a high titer or normal antibody response to vaccination against COVID-19, while patients with very low numbers of CD19 positive B cells may have low titer or no titer still, and patients who have no B cells in circulation most often developed no antibody in response to their vaccination. Based on these data, we would suggest that delaying treatment with rituximab or ocrelizumab until B lymphocytes start to return in circulation may be the optimal strategy for guaranteeing an antibody response to the vaccine. In conclusion, to summarize the studies that I've been explaining, we found from the COVIMS registry that risk of severe COVID-19 was similar in people with MS and was seen in folks of advanced age, Black race, ambulatory disability, and comorbid cardiovascular disease. Hospitalization was more common in people treated with rituximab and ocrelizumab. Vaccine studies have now shown that rituximab, ocrelizumab, and fingolimod, and some related medications that affect the S1P receptor, often reduce antibody responses to COVID-19 vaccines. However, T-cell responses are preserved in patients who are on rituximab and ocrelizumab who fail to develop antibodies in response to their vaccine. And we believe that optimizing vaccine response in patients on anti-CD20 medications, rituximab, ocrelizumab, and ofatumumab, which goes by the brand name Kesimpta, will likely require strategic timing and use of laboratory blood test monitoring to determine the right time for administration. Thank you.